Hi, I'm Dr. Dai Chung, Chief Medical Officer of the Joint Pediatric Enterprise between UT Southwestern and Children's Health. Welcome to this new segment of the In the Know video series. In these videos, I'll sit down with various physicians to shine a light on the clinical excellence, innovation, and medical advancements that are happening across our enterprise. I look very much forward to sharing this incredible work of our colleagues to transform pediatric healthcare in North Texas and beyond. Today, we're here with Dr. Lawson Copley. He's our pediatric orthopedic surgeon at Children's Health and the program director of Musculoskeletal Infection. And welcome.
Yeah, thank you.
I'd like to know a bit more about you, your program, as well as what all great work that pediatric orthopedic group is doing at Children's Health.
I've been here for almost 19 years now, but it's been a great experience as we've gotten into this. One of the first patients that I encountered on the ward was a child with musculoskeletal infection, a boy who had had 6 surgeries to that point to try and address a very challenging hip infection. Involved the bone of the upper femur and the hip joint and the muscles surrounding that area. I started to recognize in those first few weeks of practice how much musculoskeletal infection was in the community. Something about temperate climates in the United States that drives these infections and the local bacteria that are involved. And so we saw how much volume there was, and the thing that dawned on me as I was going through the processes of care was how variable the treatments were that we were doing. Part of that was due to the fact that these children were going to 10 different hospital units within a very large organization on 6 different admitting services to at least 60 admitting providers. And so we decided to study the clinical epidemiology of the disease to see how much there was actually that we were treating, and also the processes of care. So this team that was assembled, it included 33 members from all the different stakeholder groups that might touch the patients that we treat. Recognized right away we could do better. We could make improvements. And so I volunteered to write a guideline to cover the main types of infections that we treat. That's been the secret of the success of the musculoskeletal infection program, that it is truly multidisciplinary, that it encompasses a lot of diseases or conditions that aren't musculoskeletal infection but come in looking like it. And because we take this very systematic and process-oriented approach, we're able to very quickly spin off, this is more likely to be rheumatology, hematology, oncology, orthopedic oncology, fractures, and then we can get the patient into the right bucket of the Venn diagram.
Dr. Copley, that's an amazing history and overview that you just shared. I mean, that if there were anyone out there in our community who weren't quite familiar with MSI, there you go. Share with me some specific patient case scenario example. Are we talking kiddos that may have gotten injured from a multi-vehicle accidents, or what is it when we talk about MSI?
Yeah, so children are a bit unique, talking about largely a healthy population that have no immunocompromise that we're aware of. And we've looked, and especially in the more severe cases, they acquire the infection through the bloodstream. How the bacteria gets into the bloodstream, nobody could really tell you. It's not through a cut, a scratch, a scrape, any surgical procedure, anything like that. The bacteria then circulate through the bloodstream, somehow figure out how to survive, and then go into either the end of a long bone or a joint space or a muscle and initiate an infection. And there is a history of minor trauma in about 50 to 60% of the children that we treat. And it precedes the infection just by a few days, and the family remembers it very clearly. Something happened, but the child was fine afterwards. They continued to play the sport, continued their activities, and a couple of days later, they started getting fever and then feeling symptoms in that area that had been traumatized. It's not a major trauma. They don't break their bone, they don't get a torn ligament or something. For some reason, those patients don't get infected. But maybe the minor trauma leads to extra circulation that goes to that region of the anatomy, and a little bit of bacteria that happened to have been in the system finds its way. But the cases that I get involved with are the really sick kids. They'll come in septic shock and go to the ICU. Some of them spend time on ECMO, and in fact, a child I saw in clinic today had been on ECMO for 8 days. Prior to the time when we could actually get an MRI to see the infection where it was. And she'd had an ankle sprain. A few days later, started getting the fever, the pain and swelling, and then fighting for her life. That child we took to the scanner the day she came off of ECMO, or actually it was a couple days after when they stabilized her. And I was there in the scanner when it was being done because I knew we would find surgical problems. And we scanned all of the area where she had symptoms right before she came to the hospital. And there were 8 different foci of infection. Several bones involved, some joint spaces, muscles, abscesses. And so I evacuated all of those sites in a single surgery.
It's just an amazing and phenomenal program that you have. Do communities in the region and the country, globally for that matter, people are well aware of this exceptional program that you built?
Yeah, increasingly so. I have been asked several times to be visiting professor to talk about this program. And something that I think is lesser known by the pediatric orthopedic community, because I get a lot of calls from other hospitals, not only in the United States, but even in other countries, where they're struggling with these challenging cases. And they tell me about all the different minor procedures they did and all the MRIs they obtained, and asking why the patient's still not getting better. And so the procedure that we've evolved to perform here, which has been developed over a couple of decades and all the experience of all the kids with osteomyelitis we've treated, is extremely aggressive debridement of the cancellous bone in each of the foci of the infection. We make a cortical window right over that metaphyseal cancellous bone in each of those areas where we see findings on MRI. We drain any subperiosteal abscess, but I enter that cancellous bone and I remove it all with a curette. I leave the growth plate and I make sure I'm entering the diaphyseal, the medullary canal. And then I leave good drains in the bone and around the bone and close like I'm never coming back. And the cancellous bone is the fuel for the fire. It's the nutrition source. It's where the bacteria harbor, and why these kids are bacteremic for days on end, even while on appropriate antibiotics, is because the cancellous bone is part of that endosteal circulation. The big blood vessel flows in, picks it up, and flows right back out through the big vessel, and it's always in the bloodstream. They don't have endocarditis, but they're bacteremic. That girl was bacteremic for 10 days. But once we did that procedure, a couple of days later, she stopped being bacteremic. So I think that people are increasingly aware of what we do and how we do it, so they want to know the answers. They want to apply these types of principles in their own setting. There are now big study groups that are involved specifically to look at these questions in tertiary pediatric medical centers across North America. One is the Pediatric Infectious Disease Society and Infectious Disease Society of America. They assembled a study group to write guidelines that could be used nationally. And that group has been in existence for 11 years, and I've been on that group. It's mostly infectious disease doctors, but they are fascinated with what we do here.
Wow, that's just really amazing feat. I mean, we truly have one of the world's leading authority in our own campus. So Lawson, what more can you tell us about your program?
I think the thing I'm most proud of is the collegial feel of the program. There are 103 pediatricians and subspecialists who have received ABMS board credit for participating, and they do so out of a common desire and a passion to take better care of children. This is a team program, so I don't want to take credit for it. And obviously the existence of it started with an idea, but the continuation of it continued with dedicated work of a lot of great medical staff that are here at Children's.
Now, with all that going on, I mean, what do you have free time, or what do you do? I mean,
I did my active duty Air Force a long time ago, 97 to 2001, and I loved it. In 2011, I went back into the reserves. So I've been serving, I'll reach my 20th year of Air Force service this August. And so I am the medical squadron commander in Fort Worth at the Joint Reserve Base. We're a fighter wing, so we have 1,800 members of the fighter wing that we take care of. Our squadron is the largest reserve medical unit in Air Force Reserve Command. We have 250 members that I'm responsible for. We're ready for combat, contingency, humanitarian assistance operations. And then I'm a flight surgeon as well, so I get to go up with the F-16 team, and so it's a lot of fun, but it's a big commitment. So most of my vacation time for the past 11 years has been used to serve in the Air Force.
Your background in military and principles of being a soldier, it's just I see so many kind of have translated into your clinical practices, emphasizing teamwork, and everyone has something to contribute to better as a whole team. This is really an incredible story. Thank you very much for sharing some of your journey, and we look forward to your continued success here for years to come.